Welcome, everybody. As advertised, I'm not Will Dixon, but I'm Charlotte Sharp. I'm a senior clinical lecturer based at the University of Manchester and a clinical academic rheumatologist. So we're absolutely delighted to welcome you today to celebrate the second part of the Data Jigsaw programme, which has been a real labour of love for all of us over the last 2 to 3 years. So we've got some great speakers today. We're going to run on until 2:30, and the focus of the seminar is data access, linkage, and public trust. I think we're just welcoming Anne Kinderlehrer. Anne, is that you saying hello? Anne, are you there? Not sure. Anyway, Anne is one of our discussants, so hopefully she's able to hear us. We can't see her, but I might just pop her on mute. Not able to do that. Maybe one of the other hosts might be able to do that. Fantastic. Okay, so we're going to have a brief introduction and then welcome our first speaker. So just to put the Jigsaw program into context, this is electronic health record research. So we know that health data supports clinical care. It's incredibly helpful to us clinicians. And there are also lots and lots of opportunities to support research so that we can give patients the best possible care. Thank you. So, however, because of the availability and quality of data, we're currently limited in the research that we can conduct and therefore how well we're able to optimise our care for patients. And we're using musculoskeletal research as an exemplar for the kind of data linkage analysis that we could do in other conditions. So one of the key challenges for data in electronic health records is that it might not be there, it may be absent. It might be inaccurate. For example, for the clinicians on board, this has been coded as rheumatoid arthritis, but in fact, those are osteoarthritis nodules, so it might not be correct. It may be unstructured, so a long clinic letter with lots of prose in it, but no specific codes that we can then usefully lift in a quick and efficient manner. And it's often siloed, so historically, health and social care records have not been connected. So the Data Jigsaw is a local data integration pilot focused around Salford. So we want to thank our Northern Care Alliance colleagues for their work in helping us to integrate those data. And what we aim to do was to pilot novel data collection, extraction and integration, specifically within rheumatology, but thinking about how that can be expanded to other conditions, so that we can answer these important research questions. And alongside that, we've been investigating how we can maintain public trust, which is hugely important for patients when they are agreeing to share their very important health data with us, and to think about how we can sustain and scale up the findings and learning that we've made through this programme. So the data sources that we've used through the Data Jigsaw include primary health electronic patient records or health records, hospital letters from outpatient clinic visits, inpatient electronic health records, of which Salford was a pioneer, web-based surveys which have been designed for patients to complete online or on their smartphones, it's social care records and community records as well, and interviews and focus groups. Sorry, I lost the text on the bottom of the screen just there. So without further ado, we will move on to the next slide if that's okay. Or what are we doing here? Sorry, I'm not clear about that. Fine. So this is a short introduction to the Data Jigsaw and animation for you to enjoy. That's great, thank you. So I should explain my role on the programme has been as knowledge mobilisation lead. So in normal words, that means trying to get research into practice and make it easily understandable by as many people as possible. So that animation was designed to try to bring together some of what we were hoping to do for the programme, which will hopefully be understandable to academics, clinicians, and to the wider public as well. So we're going to focus today on data and public trust. We're going to begin with a presentation on public notification of data sharing, which, as I said before, is really key to being able to do any of these types of work. We'll then move on to understanding how outpatient clinic letters can be text mined to help classify disease more accurately. To think about how we can structure data collection in hospital outpatient departments to make it more amenable to research, and then have a panel discussion from Professor Dixon and colleagues around the logistics of a programme like this, which has been interesting throughout. Okay, so I'm going to first of all welcome Professor Caroline Sanders, who's Professor of Medical Sociology and lead for the Public Trust work package for the programme. Over to you, Caroline. Thank you.
Thanks, Charlotte, and hello, everyone. I'm really delighted to be talking to you today about the work we did within the Jigsaw programme for our theme of work focused on building and sustaining public trust. In particular, I'm focusing on the work we did to co-design, deliver and evaluate a notification campaign about data sharing for the Jigsaw programme. It was a really large team effort. Some of the team are mentioned there, and I'll mention the fantastic work of our public contributors and the comms company True North in the presentation. Next slide, thank you. So there's been a lot of research suggesting that most patients are positive and altruistic regarding confidential reuse of health data. However, there's also concerns about privacy, security of data sharing, and there are known variations with levels of trust according to factors such as age, and also ethnicity, etc. And this has led to the view that we need to do much more to enable the voices of seldom heard communities to be part of public dialogue associated with the governance of data sharing, and to give greater transparency to work done using healthcare data. Greater public confidence has been reported in healthcare organisations, including the NHS, and also educational institutions such as universities, rather than commercial companies. And issues such as low awareness, consent preferences and security remain areas of key consideration. So one solution is to ensure communities are notified, and that's what we were aiming to do in this programme. Next slide. Okay, so our overall objective was to understand diverse perspectives on data sharing and how best to build and sustain public trust. And in order to do this, we planned 3 components of work. First, some qualitative research to explore perspectives on data sharing across diverse communities. Second, we planned to co-design materials for a public notification campaign in partnership with our public advisory group and a comms company called True North. And third, we wanted to evaluate the usefulness of the campaign. And the work fills a gap in focusing on specifically on musculoskeletal conditions and marginalised communities. So next, public and patient involvement and engagement has been crucial throughout the work. And for this, we had involvement from our public contributors listed here, Joyce Fox and Jane Taylor, who worked across the whole Jigsaw programme. And for our public trust work, we worked with our advisory group, including Owen, Jenny, Katie, Jav, who met on a regular basis throughout the work, and additional input from Pat Walkington, who helped facilitate community discussions for our notification campaign. And we also had links with many community-based organisations, including some of these listed here, and were often facilitated through members of our PPI group as well. Next slide, please. So what did we do for our methods? For the research and engagement, we conducted 8 focus groups, 4 prior to development of the comms campaign and 4 following for evaluation purposes. And we conducted 20 semi-structured interviews, and in total 48 participants took part. Just over half were women. There was good spread across age groups, and around 1/3 classed themselves as from ethnic backgrounds other than white British. And to enable wider engagement, we with affected communities, particularly members of underserved communities, we also had additional informal discussions. So for co-design and development, the main idea was that both the PPI work and the findings from the qualitative research would feed into development of the notification campaign. We conducted multiple workshops with the PPI group in partnership with the comms company True North in order to co-design materials for the campaign. And this was completed in multiple stages. We worked together to develop a comms strategy and storyboards to reflect value propositions. And these led into development of a brand identity and a toolkit of assets to be used within the campaign. And we also used those same brands, the brand and the assets for the website as well to tie it all together. Next slide, please. So this slide just shows some of the issues that were initially raised in discussions with our PPI group in terms of what we needed to do. First of all, we needed clear and simple messaging. And they also highlighted that stories of patient experience relevant to data sharing was really valuable for conveying messages, and the value of different formats such as animations. Also, they suggested talking heads films where we would film researchers explaining the research. And so we used some of this to test out in the early stages, and that we needed information on security and data use. Next slide, please. So in terms of the qualitative research, there were three main themes identified from that work. First of all, awareness of and motivations for supporting data sharing for musculoskeletal research. So within this, when asked about views, individuals reported a perceived lack of awareness about data sharing and not necessarily knowing what it entailed, similar to other research. And there were also misunderstandings about how de-identified data can be used without individual consent for research purposes. Many also felt that the NHS opt-out should be made more transparent. And although there was general lack of awareness, many participants were motivated by the idea that musculoskeletal research could help them directly because of personal experiences, but also demonstrated altruistic motivations, sharing data for the greater good. In terms of issues of security and sharing data, privacy concerns remained a prevalent issue through the discussions. Some participants mentioned concerns regarding stigmatization that might be made worse by sharing beyond the NHS. However, many were positive when discussing specific examples within the Jigsaw programme, such as sharing social care records to understand the impact of MSK conditions, or working with a private company to develop an algorithm to improve diagnosis. Thirdly, transparency and communication needs. So transparency about data sharing and governance was considered vital, and participants felt that methods we should have simple messages and also need to acknowledge digital inequalities so that many people wouldn't necessarily access information online. They also felt a key message was to relay to the public that their data was being used for research and it was being kept safe. So again, emphasising the data privacy. And that just on the right-hand side of the slide shows a screenshot from the research paper that was published in Journal of Medical Internet Research based on the qualitative part of the work. Next slide, please. So this slide gives an idea of the initial messages and narratives used to reflect and build upon discussions with the PPI group and on the qualitative research in terms of what should be conveyed in the campaign. True North drew on the initial work to draft 4 propositions based on the target audience and to raise awareness about the work going on within Jigsaw. And a key aim was to develop materials that would resonate with personal context and values, as well as the credibility of work. I don't have time to go into the detail of these draft stories, but a variety of language was used across the 4 narratives, with some focusing on personal benefit, i.e. there's a close benefit to the individual when sharing data for research, and with others focused on communal benefit, the idea that the community can benefit. And the PPI advisory group and the team were asked to comment on these initial drafts. Next slide, please. So this slide shows the favoured image. People felt that it helped convey a sense of inclusivity, that people from diverse backgrounds with musculoskeletal conditions could see themselves in this image. or set of images as it's put together. And the main message was amended to reflect a blend of the narratives on the previous page based on the discussions that we had within the PPI group, and especially to give a sense of the importance of working together, i.e. patients, members of the public and researchers can work together through data sharing to improve care in the future. Next slide, please. Now, this slide shows the final set of materials developed by True North for the communications campaign. And so these included images for posters that could be used in a variety of settings, a leaflet that could be circulated in community settings, and also social media adverts. Next slide, please. So this slide shows an animated image summarising the community context in which the campaign was implemented, including posters at bus stops and billboard adverts. The idea that we wanted exposure in everyday lives, that it wasn't dependent on people going online. The picture on the right shows a billboard up in the Salford area during the campaign. Next slide, please. And this slide just illustrates some of the wider community engagement we conducted, including a photo of the discussion group we held at the community allotments in Salford, run by an organisation called Growing Together. And here we were able to take some of the materials developed for the campaign, as well as enabling wider discussion and Q&As about the work. Next slide, please. Now I just want to show this short video. This was developed to explain secure data environments based on feedback from participants about the need to raise awareness and accessible materials.
Confidence in the secure management of health data comes from the 5 SAFES principles. Safe people. Only trained and accredited researchers are allowed access to the data. Safe projects. Before access is granted, projects are assessed to see whether they are an appropriate and ethical use of the data and whether they will deliver public benefit. Once approved, they can only use the data for that purpose. Safe settings. This principle ensures the secure computing environment where the data lives is indeed secure, and that data cannot leave the secure data environment. Safe data. Researchers are only granted access to data that has been de-identified to protect privacy. Safe outputs. The research results that are taken out of the secure data environment are checked to ensure they cannot identify any individual people. Confidence.
Okay, so next, I won't talk in any depth about the evaluation, but just wanted to make a couple of points here. One, that we did when we initiated the campaign, we were ready for a public response, and we formed a group ready to take any questions and queries from the public, thinking there may be a fair bit of feedback, but actually contact to ask questions about the campaign was minimal. Somebody contacted asking for further information. But overall, from the evaluation, respondents were very positive about the campaign and viewed the materials as being eye-catching, easy to understand, the information being clear, etc. Next slide, please. Just final words for discussion, just to summarise. I think that this work demonstrates the value of co-production for tailoring communications to reflect current and local research. So in our case, doing this work within Salford and working with local communities, and that targeted and accessible information in affected communities and community-based dialogue can help to build and sustain public trust. So also a point that was made towards the end, that we didn't have capacity to do translation of materials, but we felt that was something that could and should be done for other campaigns, and that findings can be extrapolated to other conditions beyond musculoskeletal conditions, making these findings relevant to a wider community. Thank you.
Thanks, Caroline, so much. That was a really interesting overview of all the tremendous work you've done on that work package. We don't have a discussant for you, but I think that it's really important to highlight that one of the real strengths of your work was the informal group discussions that you had beyond the more sort of formal qualitative interactions. Would you just give a tiny, perhaps a 30-second summary of how you went about in sort of embedding yourselves within that community and engaging their trust?
Thank you, Charlotte. Yes, I mean, I guess key to this was, as I mentioned earlier, was some of the established links we had with community-based organisations already, and also links that were facilitated by members of the public advisory group in particular, who had strong links. So I think the fact that we were working in partnership with trusted individuals embedded within communities made that much easier to enable us to just be able to drop in, have informal discussions in those spaces.
That's great, thank you. So the strength of relationships over a longer period coming to the fore there. Okay, that's brilliant. Thank you, Caroline. So we're going to move on now to our next speaker. Before we do that, I would just really love to invite the audience to put questions in the question box. So that is at the bottom of your screen, or wherever your bar is. There should be a little box where you can pop in questions. We will invite the panelists to respond to those questions in the discussions as appropriate, and they will endeavour to respond in the chat further on in the seminar as we move along. So it would be brilliant for our discussions if the audience would please pop some questions in there. All right, so if we move on to the next slide, I'd like to invite Professor Will Dixon, who is Professor of Digital Epidemiology and an Honorary Consultant Rheumatologist at Salford, to do his presentation. Will is the Principal Investigator for the programme, and you'll be hearing from him a little bit later on as well. So thanks, Will.
Thank you, Charlotte. So I'm going to talk about how we made use of text mining outpatient letters and how that helps us develop more accurate estimates of the prevalence of disease. So the prevalence of disease, how common something happens, is really important. It's typically the first line of any funding bid that you read or any policy work. So, for example, psoriatic arthritis affects 1 in 300 people. And we get that number by counting the number of people who have disease out of the whole population. So this is what we want to know. We want to know the number of people who are disease positive. In this 2x2 table, it's cell G. And then we divide it by the total number of people, which is cell N. This is often done using routinely collected data, electronic health records from primary care, and we identify people who are living with disease by code lists. Have they got a diagnosis for psoriatic arthritis? And here's a publication from the Kiel group who've done just this, looking at the prevalence of various different types of inflammatory arthritis. What you get from such an analysis is the number of people who are code list positive, which is cell E here, over N. But this is slightly different from what we actually want, which is G over N. You can then do validation studies which allow you to discover and exclude people who are falsely labelled as having the disease. So you can separate out the true positives from the false positives. And you can do this through case verification. So you go back from those cases of psoriatic arthritis to the gold standard, for example, hospital outpatient letters, and rule out people where they didn't have a diagnosis. So what that would then give you is A over N, but it's still not quite what we were hoping to get. And the missing ingredients here are cells C or G. What you then have to do is to try and work out who didn't have a code, should have had a code, and you're trying to separate out the true negatives from the false negatives. But this is in fact like looking for an invisible needle in a haystack, because you're looking for codes that don't actually exist. So this is nearly an impossible task. So what we've talked about so far is primary care data, data from general practitioners, but of course patients see doctors in different settings. And why don't we just use information from hospital if that's considered the gold standard? Well, one of the problems is that you don't know the denominator, because there are patients who are seen in a local hospital who come from out of area, and there are also patients from that area who are seen at hospitals that are further away. So you could count how many people have psoriatic arthritis in a hospital, but you wouldn't know out of how many people that is. The second really difficult problem is that the information that we collect in certain parts of hospital, particularly in outpatient settings, is not structured, which means that it's not machine readable. We can't pass it through a computer to count how many times psoriatic arthritis is mentioned. But there are advances in computer science that allows us to do methods to help the computer extract from this text coded and structured information. So on the left, you can see a mock-up of an electronic health record, sorry, an outpatient letter. You can see at the top part of that letter describes the diagnoses. We can then separate out the diagnoses from procedures like a coronary artery bypass graft, CABG. And then having found these pieces of text, we can then map the diagnoses to a coding dictionary such as SNOMED. And here we're using a tool that was developed at King's College London called MedCat. So the aims of the piece of research that I'm going to show you, we're interested in measuring the prevalence of psoriatic arthritis, but we explicitly want to examine and adjust for the misclassification that you might see in primary care data. So finding the the false positives and the false negatives. So our specific objectives are estimating the prevalence using primary care data alone. This is what other research groups typically are able to do and very commonly done. But then in a subpopulation of patients where within Jigsaw we've taken the time and significant effort to link together their primary and secondary care data, we then identify the false positives. In that same subpopulation, identify the false negatives. And then based on that understanding of how many false positives and negatives you get, we then update the prevalence estimates for the whole population. So we're going to take data from two different sources, from primary care electronic health records in Salford. That's a population of around 200,000 people. And then we're also going to take the rheumatology outpatient letters from Salford Royal Hospital over the same 6-year period. And then we bring together those two data sources, having text mined the hospital outpatient letters and link them. And this is the thing that is particularly challenging and not available to most research groups. In primary care, we identify cases of psoriatic arthritis using a very broad definition. We don't want to miss cases. So if you had a code for psoriatic arthritis, or if you had a code for psoriasis and arthritis and the sort of medication that we use for psoriatic arthritis, or if you have a combination of codes for seronegative inflammatory arthritis and psoriasis, any of those will be classified as a case. And in the hospital, we text mine the letters, we fill SNOMED codes for psoriatic arthritis, and then we manually go through every single one of those cases that we found to ensure that the text doesn't say things like no evidence of psoriatic arthritis or family history of psoriatic arthritis. So we don't want to falsely find cases because it's either negated or talking about family history. So let me show you the results, and we're going to fill in that 2x2 table that I used to explain what we're looking for. So we first of all look in the whole of the population of Salford, nearly 200,000 people, and using primary care code lists, we found 245 cases of psoriatic arthritis. And if we stop there, that would give us a period prevalence of just over 0.1% of the population. And this is in line with what we see in other studies. But we didn't stop there. We want to go on and look at the population who have linked data from the hospital. And we found that about 4% of the Salford population was seen in rheumatology over a 6-year period, and that amounted to 7,500 people. So if we now focus solely on those people who are Salford residents, who are seen in Salford rheumatology outpatients, of those 245 cases, 202 of them had been seen in the Salford outpatient clinic. When we then look at whether those 202 cases identified in primary care turned out truly to have psoriatic arthritis, almost all of them did. So the primary care code list was doing a really good job. You could be reassured that our estimates were pretty accurate. And this is usually where research has to stop, because you can't find those invisible needles in the haystack. But in our example, we have linked to the hospital data, and we can then see how many cases were visible in hospital that we hadn't picked up through primary care. And the results that we saw for that was that there were, in fact, slightly more cases that were missed from the hospital setting where they were not visible in primary care. And when we updated our prevalence, remember it was 0.13% before, the updated prevalence adjusting for this misclassification means that we got a result of 0.25%. So quite a difference in how commonly disease exists through this linkage. We wanted to look at the details of where there was discrepancy between the hospital doctors and the GPs. First of all, we looked at those that were picked up in primary care but not present in the hospital. And most of those, the hospital letters said things like psoriasis or psoriasis and osteoarthritis or rheumatoid arthritis, where we were pretty confident that actually the diagnosis in GP was incorrect. But there were a few where there was complex wording and the text mining missed them. When we looked at these 196, which is the sort of striking finding, we went back through the hospital letters and we actually looked at the level of certainty within this. The proportion of people who had possible or probable cases was higher than it was where the primary care code had identified it. But the hospital specialists still thought that this was possible or probable. And over 60% were all definite. So it's not like these are bogus cases. These were missed cases in primary care. Unfortunately, we couldn't determine exactly why we'd missed them in primary care because the data that we had accessible was only those codes that allowed us to define psoriatic arthritis. So we couldn't really understand the reason that they were missed in primary care. So the summary of the key findings, our original prevalence estimate was 1.3 cases per 1,000 people, but this missed around half the cases and our updated prevalence roughly doubled. The real strength from this is that the text mining of the outpatient letters allowed us a gold standard diagnosis, and all of those text mining algorithm-derived cases were manually reviewed, so we're certain that they were correct. The broad code list in primary care meant that we were unlikely to have missed cases from the GPs. But I think more broadly than this example in Jigsaw, it's important to highlight that across hospital outpatients, not just in rheumatology, but in gastroenterology, in neurology, in dermatology, and not just in Salford, but in all hospitals across the country, there's no readily available diagnoses, which means that we can't use the hospital specialists to count disease, to look at outcomes of disease. We learned that it's important to carefully verify the cases from primary care, the benefits that you get from linked data across primary and secondary care, and the opportunities of making use of this free text. We've got over 15 years worth of digital outpatient letters in Salford, and yet we're not making use of them for research and other purposes. And I think it's quite an exciting time because there is current progress in digital infrastructure around the country for health data research that is providing a new opportunity that can increase both the accuracy and impact of such population health research.
That's brilliant, Will. Thanks very much indeed. Lovely. So I'm just going to encourage the audience to continue to pop your questions in the chat. You'll see that the speakers who they relate to will respond to those. And I'm going to invite Karen Hodgson, who is Head of Health Intelligence at Versus Arthritis, who's our discussant for Will's talk. So welcome, Karen. Thank you.
Thanks very much. So as Head of Health Intelligence, my job is really about making sure that there's the right data on the experiences of people with various arthritis conditions that we can pass on to decision makers across the health and social care system and wider systems to make good decisions, evidence-based decisions that support people with arthritis. And as Will says, actually the most fundamental question that gets asked first in those conversations as well is how many people does this affect? And I think what's really important here is that we need to go into these conversations with really reliable and timely information, because otherwise, you know, if we know that our data is very biased or it's very out of date, actually the ability to kind of drive the urgency of the conversation is really undermined. And I think when we think about where this data comes from, we know that it needs to go from the person with the condition to the healthcare professional, then into the patient record or the letter. And then it needs to be linked into a data system that then an analyst can find and pull that data out from. And we know across all of those areas, we've got a huge number of different blind spots that means our data is unreliable or biased in different ways. And I think this project's really interesting because when you're talking about rheumatology and other outpatient kind of areas, we know that we have a really big blind spot within the NHS in terms of understanding what's going on in that space. And this ability to kind of pull that data in and put it together with the primary healthcare records means that actually we're starting to address some of that blind spot. And it's really striking the big shift in the prevalence. Yes, it's still not a common disease, but actually moving that prevalence means that we're much better able to advocate for the actual need and the provision of services that are appropriate based on that number. So I think this is really exciting, and I'm keen to see more things that come in this space and start to pick out those different biases and blind spots that we've got in the data.
Thanks, Karen. Will, did you want to respond to that at all?
No, I mean, I think we always set this up really just as a single example, but to illustrate the opportunities that there are, this sort of missed opportunity from the data that exists, show some of the limitations of just using primary care data. I mean, it is widely used, it's really valuable. We've learned an awful lot from primary care EHR research, but identifying the fact that there is this gap, that it does make a difference, and that we need to work to get better quality data. We shouldn't really have to text mine it. We should collect coded structured data as part of routine care as research quality. And then, in fact, that's what we're going to go and talk about in the next talk.
Thanks, Will. And I guess, Karen, from a kind of funder and patient advocate perspective, there must be a call for lots more work like this. Is that something that VA is focusing on, or from a VA point of view?
Yeah, definitely. And I think, you know, across all the different arthritis conditions, there's different challenges in different spaces, but this is one of the big ones. And I think when Will and I spoke a couple of weeks ago about this, you know, the Sudlow review is talking about how trying to kind of improve that diagnostic data in outpatients and bring that flow in. And I think that's really important. You know, it's such a big area of care and it's just invisible to us. So we should be addressing that.
Yeah. That's great. Lovely. Thank you very much indeed, Karen, for your contribution. We're going to move on now to our brilliant research associate, Dr. Susie Moschogianis, who is going to talk to us about structured data collection in outpatients.
Thank you, Charlotte. And thank you for inviting me to speak today about this work package that was led by Professor Dawn Dowding. So yeah, I'm going to speak about towards structured data collection in outpatients. Next slide. So as we've already heard about earlier, research using routinely collected health data can answer important research questions, but as long as the right data is accessible for a given research question. And despite all the necessary data items being in existence, however, these items are not yet available altogether in the same data set and are not formatted in a way that makes them amenable for research. So this was our starting point. And we wanted to understand, first off, exactly how data is currently collected and used in clinical care. So is it in fact imperfect? And could we enable high quality data collection for clinical purposes that can then also flow for research? Next slide. So to understand what happens currently, we started with doing observations across 2 different NHS trusts, and we used data journey modelling to map and capture the movement of data across networks of people and systems. And I'm not going to get into it in too much detail. You can see here, this is one example of one observation I did. You can see, you know, this will visually give you the idea that it was many, many steps and it's very complex. If we can have the next slide. This is what a lot of the models look like. Lots of copying and pasting from one place to another, very, very messy. But it did highlight that the previous clinic letter is the key source of information. It's sort of used as a rolling record of the patient's history. And the work involves transforming the data from the consultation back into another clinic letter. Next slide. So then we did some interviews with healthcare professionals in rheumatology outpatients, and these interviews revealed the hidden data behind these messy data models. Interviewees described overcomplicated systems where it's difficult to find key information quickly, inaccurate and missing data. You can see from these example quotes, one of the biggest issues was trying to find the right information quickly. Next slide. So structured data collection using electronic health records seems an obvious solution for direct care and secondary uses like research, but there are significant challenges which we also explored with our interviewees. We found that clinicians are reluctant to enter coded structured information. I think prior to Jigsaw, attempts were made at Salford to develop structured data entry forms, but it wasn't actually used because it was suspected that the clinicians wouldn't actually do it because there wasn't a direct benefit for them. And this is certainly what came out in our interviews. So we have this resistance from clinical staff who feel it might be an administrative burden, and staff fed up of familiarising themselves with countless new systems. People also acknowledge that hospital electronic record departments don't have the capacity to develop multiple bespoke data entry systems for the various outpatient specialities. And we also know that there's a lack of flexibility on what you can and can't do within existing systems. But so our main conclusion, though, was that users need a return on their initial time investment to enter this structured information. There has to be a tangible benefit. Next slide. So going back to our research questions, we then asked, can we design a usable system for use in outpatient departments that can also increase the accessibility of data for research? So this is an overview of the design process we used for our prototype. So we use these findings from all our observations and interviews to identify current issues in the systems. We also asked participants to do a bit of blue sky thinking. What would an ideal system look like to you? And then we use these findings for an initial prototype. And we had a sample of 4 experienced rheumatology consultants with research experience who we used as our expert panel, and they provided rapid feedback so we could develop our final prototype. And this is what our prototype summary page looked like. It was a web-based design developed in the program Marvel. We can see here the summary page, including patients' rheumatological and non-rheumatological diagnosis. There's a separate research tab at the bottom on the left there, where active study participation information would go in and be stored and accessed. If we go on to the next slide, though, you can see here for our example patient, Rosemary, who has arthritis. You can see here this longitudinal visual summary of disease severity and medication use over time. And it's color-coded according to disease severity. So red for measurements outside of the guidelines. And it also has if you click on the little arrows, it would give you more information on the start and stop dates of each medications. And crucially, also the reason for stopping each medication, because this was a key bit of information that both clinical and research nurses said that they routinely needed and struggled to find easily in the clinic letters. If we move on to the next slide, this should be an image of the patient visit screen. So this is where data would be entered during or straight after a clinic visit, which would result in the automatic generation of the patient's clinic letter, which then in turn would populate and update that patient longitudinal summary that we've just seen. So moving on to the evaluation of our prototype. So all data was fabricated based on common patient stories from rheumatology outpatients and pre-programmed into the design. We asked staff to complete 3 short tasks tailored according to whether they were clinical staff or research staff. For example, if they could screen a patient for taking part in a particular study, or if they could find all the information they needed from the patient record prior to their follow-up appointment. And Then participants undertook a brief qualitative interview with myself, which was a chance to explore further their thoughts on the prototype. And finally, they completed the system usability scale. So moving on, how usable was our system? So a system usability score of 71 or higher is usually considered acceptable, and our system scored 88, suggesting very high system usability. And if we go on to the next slide, we can see the quotes here from the interviews that illustrate that for the participants, this longitudinal summary was the key advantage over their current system, not just for information retrieval, but also as a visual tool to engage with a patient during their session. So this was the key benefit for clinicians, providing a return on their time investment. And it's worth noting for this longitudinal summary that very little limited information is actually needed to pull this together, but it adds major value. And it can also be useful or easily translated for other long-term conditions. Next slide. So people did suggest further modifications. Some people did ask for there to be an option to open all the clinical letters at once, sort of the return to the rolling record way of doing things. And quite a few people asked if additional information on electronic patient-generated health data could be incorporated into that longitudinal summary, perhaps with a function to toggle on and off. So patients could provide additional information in between clinical appointments, and that would provide an even more comprehensive picture. So to conclude, clinicians need to have a return on their time investment for collecting coded structured information, and this visual longitudinal record we found adds significant value for both clinicians and research staff. We've used rheumatoid arthritis as an example, but it's likely transferable to most outpatient specialities. But we do have this challenge of how to integrate. This feature needs to exist within current systems, or providers need to enable innovation through plugins. Next slide. It's a challenge we need to overcome to enable better clinical data collection with benefits for patients, clinicians, research staff for when screening for studies, for example, and to support research. And I think we're going to end now with a short animation that brings to life a few pieces of the Jigsaw work, including this work package. Thanks, Charlotte.
Brilliant, Susie. Thanks so much. That was a really, really clear presentation. So I'd like to welcome now Dr. Anne Kindelera, who is also a consultant rheumatologist and is digital health clinical lead for the Royal College of Physicians. So really interested, Anne, to hear your thoughts on that. Thank you.
Thanks, Charlotte. And delighted to be here and to be looking at some of the ways in which we might make clinical digital systems better, which has been much of my focus as the RCP clinical health digital lead, is that the digital systems that clinicians use in practice are clunky, difficult to use, don't provide information in a way that supports clinicians to look after patients, don't support clinicians to give information to patients in a way that matters to patients, and don't link to each other, not only just for research, but to enable clinicians in one organisation to see data from other organisations, or perhaps most importantly, to see data from patients. And that's what this kind of working supports, is how do we build into the routine ways we work, ways that allows us to collect out of that structured data that allows us to learn, but also to be able to see and collect information fed back to us from patients. And as we start to allow what we call plugins to our clinical systems, that allows the patient portals that patients hold for them to feed data into the longitudinal record, and also patients to be able to see their longitudinal record and know how well or badly their disease is controlled. And as we start to use AI, which is much in the news at the moment in our clinical systems, for AI to work well, it needs to have reliable data sets to be trained on. In the outpatient setting, that means that we need a way of coding the information that sits in referrals and coding the disease outcomes in much the way you've seen across both these talks, all of these talks today, is we need to have more certainty about what the diagnosis reached in the outpatient clinic, and that diagnosis needs to reliably cross the boundaries between data sets, and we need to be able to see those data sets in order to be able to learn which patients are most likely to be most at risk. So systems that support us doing that in a way that doesn't burden clinicians who already have limited time will become increasingly important. So some ways of doing this are these kind of systems which support the entry of structured data in order to provide information that works for clinicians and patients. Others might be systems such as ambient listening or voice recognition, where clinicians are prompted to code as the system drafts letters or notes for them, and then that feeds into these systems more broadly. So to summarize, we need better systems that use the data that we collect routinely in our clinical practice to show us data over time to see how patients are going, so that information is useful both to the clinicians on one side and to the patients on the other, and all of our data and information needs to link.
Thanks, Anne. That's very clear about what's needed for the future. In a moment, I was going to invite Professor Dawn Dowding to come online, who's been the lead for the work that Susie was doing, in case she has any additional reflections. While we're waiting to see if Dawn would like to do that, I was really struck by what Susie was saying about there being so much resistance to digital implementation by colleagues, and thinking about how we can incentivize our colleagues to fill in the structured data that is available to some of us. My electronic health record has that facility, but only some of us do it. I suppose in the States it's incentivized by payment, because you have to code to get your payment. How can we, Anne, do you think, incentivize colleagues to try to collect the data that we need, both to feed the AI systems, to provide better clinical care, and to provide the data for research, do you think?
I think, in essence, building workflows that work is the honest truth of it. If you build a system that is easy to use, this system ranked very highly on a system usability score. Most of our clinical records, if you look at the usability scores of our electronic health records, they're right down in the bottom 20s. They rate an F on those scales. So they're at best half as usable as the systems we use ordinarily in our day-to-day life. If we build a system whereby if you enter structured data, it generates a letter that looks right to you and is meaningful to the patient that you send it to, then people will use it. And similarly, if you have a system that helps automate that workflow, perhaps by listening to the clinic, ambient listening AI, and then drafting a clinic note and a letter. But also, as it does that, saying, I think you have described a patient with these structured diagnosis, do you agree? So that you just have to tick a button beside them. If you make it easy and you make it work for what the person is trying to do, then they'll do it. If you make it really difficult and make sure that it adds no value that they can possibly see, they probably won't.
You describe a wonderful world. I look forward to living in it. Dawn, did you want to come in there?
Yeah, no, just a few reflections. I mean, I think that was the whole purpose of this part of the work, was we were quite keen to do blue sky. So really to demonstrate that if we think about designing these systems differently, with the focus being on the needs of both clinicians and patients at the center of the design, then you come up with something which hopefully would then be useful for people to actually use, but also behind the scenes provide high quality structured data that we can then use for research purposes as well. Because the whole idea would be that you just document things once and it's used across the system in all sorts of different ways. So I've seen in the chat there's some things about plugin. Yeah, that's a computer term for basically developing some software that can just be plugged in like a electric plug into an existing computer system and then be used. And absolutely, we just need, and if we have better data, then AI works better and all sorts of things. So I'm a dreamer, and I do hope that at some point the large vendors take this on board and start looking to try and make these systems much more usable for the people who are using them, because we demonstrated it is possible to come up with a different interface that would enable people to use things more effectively.
Lovely. Thank you, Dawn. Thank you, Anne, very much indeed for your insights. Apologies for the timer. That was me making sure that everybody's keeping to time. Everyone's doing a fantastic job, so I haven't had to interrupt anybody yet. So that's lovely. We're going to move on now to Professor Will Dixon, who's going to provide some reflections on running the local data integration pilot, and that will be followed by a panel discussion. Thank you.
Thanks, Charlotte. So as Charlotte mentions, we wanted to look back on the years that we've spent doing Jigsaw to try and learn lessons. That was always one of the intentions right from the outset. So let me share that experience. We'll do it by telling you where we were at the start of the programme, the justification for doing it, and then describe the things that we needed to work out as we set up the programme. And then we'll finish with some lessons learned, a case study of probably our most difficult thing that we always said was high risk, of trying to join together the hospital data with social care data, and end with a Q&A session with the panel of people who were doing all of the hard behind the scene works, both colleagues at the university and at the Northern Care Alliance. So you've seen these slides from Charlotte already. Routinely collected data supports direct care, but can be reused for research. And it has these series of problems that the data is sometimes missing, inaccurate, unstructured, or siloed. Back in 2019, when we put the bid together, there are existing research data banks that allow researchers to access primary care electronic health records. And the most common example of that in 2019 was the Clinical Practice Research Data Link, or CPRD. But over time since then, more examples have become apparent, like Open Safely, that really gained prominence during the pandemic. And the British Heart Foundation Data Science Centre have actually joined up all primary care records during the pandemic to look at COVID-related research. In recent years, the government has invested in a series of subnational secure data environments, and these are largely pulling together primary care electronic health records together with hospital episode statistics. So these new things are evolving through time, but in 2019, it was really just the primary care data. There is now increasing investment to try and bring data beyond primary care, thinking about hospital data or imaging data or genetics data. So data sources beyond primary care are coming into this emerging digital infrastructure. But there's just signs of it emerging now 6 years later. But you have to understand what are the challenges that we're going to face as the SDE programme advances into data beyond primary care. And that's the lessons that we're trying to learn through the Jigsaw programme. So as again, you've seen already, we were always a local data integration pilot where we're trying to understand issues around sustainability and scalability beyond this one example in rheumatology. We're trying to join together all of these different data sources. If we go back to CPRD, how do they do it? Well, if you're applying for research using primary care data, there is an established data dictionary, which is what you see on the right-hand side. It tells you exactly what it is that you can apply for that's collected as part of routine care. And you can also see exactly what you need to do if you want to apply for access. So you follow the link, there's all sorts of forms that you need to complete, but all of that is established. When we began Jigsaw, we had the idea that we wanted to join together these 6 disparate sources of information and make them available in a single research-ready data set. The problem was there are no assembly instructions to tell you how to do that. And so our work hasn't just been answering the clinical questions that you saw in the webinar last week or the examples that you've seen today. We actually had to do the work to bring this data together. And that's been a large part of our effort. When we began, sorry, I think I missed a slide there. When we began, we thought that the data would be transferred to us at the university. But understandably, the Northern Care Alliance, our NHS partner, didn't want the data to leave their control. And they were just starting to set up a secure data environment themselves. And so we therefore agreed that we would make their data accessible to us in the university in their Azure platform. So we would need their data engineer to pull data from the many different locations within the hospital system. A GP uses just one system. There are lots of different specialties that work in a hospital with multiple different forms. And so the engineer has to find the appropriate bit of information from the right part of the record. Then from the university, we can access that secure environment and our outputs can be checked, as you saw in the 5 saves video. But we didn't just want hospital data, we also needed primary care data. And in fact, in Salford, there has been a long-standing Salford integrated record. And so the data engineers would need to access this data, plus data that we were trying to link from outside. So you can see that this is a complex picture that we need to build up. So at the outset, we need to know what data items exist. There wasn't a data dictionary, so we couldn't go and read what we might be able to apply for. But several members of the team, myself included, are clinical academics. So we're some of the people who are entering that data in the hospital or in primary care, so we know what should be available. We then need to set up the analysis environment where the data are going to live. We said that we would transfer the data to the university, and we justified that in the bid because we had a secure data environment in the university that was compliant with everything it needed to. But as mentioned, the NCA decided they didn't want to release the data beyond their own environment. So replication, how much more I doubled. So we did then set up that environment and develop the digital infrastructure. We then had to work out how our researchers from the university got access to this environment in the NHS. And this required us to have confirmation of the ethics approval and specific study protocols for the data items that we needed. For each individual researcher, and this amounts to 29 different people over the course of the programme, we had to set up IT accounts at the Northern Care Alliance. And each of those accounts required proof appropriately of lots of different things, such as CVs, research passports, good clinical practice, safe researcher training, a scope of access form. In time, we got to understand this process, and at its smoothest, it takes about 3 months for this to happen end to end. And at the start, it took longer. So having sought out the access for researchers, we then wrote a standard operating procedure for working with confidential data in a secure data environment. So we had an information governance lead, Elaine, who led that work. And then we had to agree with the NCA how they would put the data into the right place so that the researchers could gain access to this. So they don't have a service to support research, so we had to set up a bespoke contract with the data science team and start to end in describing exactly what would be done and going through all of the legal approvals. That took about 12 months. It describes them assembling the research data sets, performing the linkage when that was required, checking the quality of the data, doing the output checking so we couldn't take out anything that was not identifiable. So we had to complete all of those steps before we even come to do the analysis. And I think hopefully you can see that that is quite a detailed and long-winded process. So I'm going to talk you through a case study, but I'm going to come back to that. So I'm going to skip over the approvals that we need from data controllers, because that really illustrates quite how difficult it is, even though you'd think it would be quite easy. But I'll move on to talking about ethics and governance. Generally speaking, if you're going to do a research study with data that come from patients and the public, you have to go through a ethics and governance process. Even if that data is routinely collected and we're using de-identified data. We decided that we would have some common overarching text for the whole of the research program for Jigsaw, and then we had specific research questions. So we decided that we'd submit individual applications to the same NHS ethics committee, thinking that we'd have about 3 or 4. And each time we kind of gradually build the complexity according to the data source, but the ethics committee would already have an understanding of what we've done before and would be able to deal with that increasing complexity. So as you've seen, we've got multiple different data sources. We showed 6 before, there's 5 listed here. And we imagined that we would submit our first ethics application that used just hospital data. The second would use some linked data. The WP stands for work packages. So these are individual research questions that we had. And then a third ethics application that would build up onto even more different data sources. By the time we finished the program, we actually ended up submitting 6 different ethics applications, all of which are long-winded processes with lots of detailed documentation. And 2 of these 6 had to go via the confidentiality advisory group, which is a more detailed, higher scrutiny level ethics process where we're linking data that don't have consent to be linked. So you have to be particularly careful that we're doing it in the most appropriate way. So if we get the right approvals in place, we then need to create the research data sets. We need to collect the right data for the right time period and with the right quality. Let's just show you an example of the right data. On the left-hand side, there is no data dictionary. So we can't tick the items that we want because there's no tick list. So the research team in the bottom right-hand corner, they need to go to the business intelligence team at the NCA, describe what we want. They need to go into the back-end system, pull out the data that they think that we asked for, and put it into the appropriate place where we can access it with the right permissions. And I think a good summary of this process is that it's a bit like Chinese whispers. There's multiple different steps, lots of different people talking to one another. The data aren't terribly well labeled in the back end of the system. And so it was not uncommon for us to receive data sets that looked slightly different from the ones that we thought that we were requesting. Of course, the NCA team need resourcing, and we knew that we would need to pay them for the service that they provided. But because they're not an established service, as very few hospitals are around the country, there was no costing model. So we had to do our best estimate in the funding bid and then negotiate with the NCA team. It was challenging for the NCA data science team because the money doesn't flow directly to them, so they don't have complete control over the money that they receive. And then there was a continual turnover and loss of team members at both ends that makes this complex communication even more difficult because there's a loss of knowledge and experience as those team members change. And then lastly, we'll just talk about sustainability before we come to the case study. This is a screenshot from our bid. We said the Northern Care Alliance has a long-term vision to develop a learning healthcare system and associated infrastructure, although there is no current allocated resource to build such a system. Our proposed work intends to shape local understanding of what research becomes possible with thoughtful data collection, linkage, processing, and analysis. We did explore the possibility of setting up a research data bank for onward sharing of the Jigsaw data. It's taken us 3 to 4 years to build up this data set, and we don't want it to go to waste. But it has proven impossible for us to onward share this data for 2 reasons. The first is that the Northern Care Alliance doesn't have a dedicated resource to support people applying for access to their research data, and somebody needs to approve the data and somebody needs to maintain control to their systems. In parallel, Greater Manchester is establishing a secure data environment, but the timing is not good because that is not yet fully operational and we can't move the data into the GM SDE. We're going to just walk you through a case study just to add some details to show you why this is just so complicated and it's taken such a long time. As I mentioned at the beginning, this is one of our most difficult things that we've tried to do. So not everything's quite as hard, so I don't want to put you off too much if you're trying to do this, but anything that we've done, it has taken some time and has been difficult. So what we're talking about here is trying to join together hospital data with social care data. So why are we trying to do this? We know that social care use is important. It's a big contributor to costs in society. We need to plan how much social services are needed for the population. We believe that arthritis is a major contributor with people's activities of daily living, their mobility compromised. But the data that you need to answer the question of how much social care do people with arthritis have is not possible to answer currently because the data are siloed. Your hospital, your NHS data knows what disease you have, but it doesn't know what social care you've had. The social care data sets know the social services you've been provided, but it doesn't know whether you've got arthritis or not. So you have to join the two together, and that's what we're trying to do here. So our aim for this research question, we haven't answered this yet, we're still in progress, is to describe social care use in people attending a rheumatology outpatient clinic, stratified by the different types of disease that they have. The methods sound easy. We're going to access and link text-mined outpatient letters. You've seen that we've been able to do that in the second presentation today. And we're going to link it together with social care data. And then we're going to do nothing more than count how many people use what type of social care according to disease. So a fairly simple analysis, but not a simple linkage. So the steps required, we need to identify who controls the data, get approvals, understand the process for linkage, get ethics for that linkage, then do the linkage and do the analysis. Let's see what happens when we try and do each of those steps. So first of all, identify the data controller for both data sets. And this is perhaps, surprisingly, one of the most painful things that we experienced. We knew at the start that Salford Council data was held by the Northern Care Alliance in a sort of historical quirk, but things changed during the course of the programme. And although it wasn't continuous effort solely on this question, persistently over about 2.5 years, we were in continual contact with the council to try and understand who controlled this and whether they would be able to release the data for research. We then needed to get approvals from the data controllers, having understood who was the right person to answer whether we could do that. And then we had to get their willingness. We had to set up data processing agreements, all of which involves contracts teams. We need to understand the process for the linkage. Our first design for this was using a third-party system called Mesh, which is a well-established system to do linkage on NHS numbers. And so we wrote all of our ethics applications and all of our agreements on the basis that we'd use Mesh. And having got those approvals, it then turns out that the council weren't able to use Mesh because it was a third-party system. And we therefore had to come up with an alternative process that allowed us to link the right NHS record to the right social care record. The ethics approval, this was one of the 2 that had to go via the confidentiality advisory group. So it's a chunky document of about 70 pages just for the CAG application. Then you have to have the research protocol. You have to describe and go through a public notification process so that the public know that you are linking their data without their consent. That required us to run a PPI workshop that gave patient views on doing this. we had to describe the data flow that you've just seen, Caldecott Guardian letter demonstrating support from our NHS partner organisation, and an ISO certificate from the Salford City Council. So we began all of that having agreed how we were going to do it last summer, and it was approved this summer. So a 12-month process to get all of the paperwork done and then doing the public notification process. But then I've already told you that the mesh process was then recognised as not being possible, so we then had to go through an amendment process. And finally, you can then go about doing the linkage and making the data available and completing the analysis. And I think our key lesson learned here is that you need an exceptionally tenacious team to make this happen. And it's not just the researchers who need to do the analysis of the data, but if you're trying to do these things for the first time, it takes a lot of trial and error and a lot of negotiation. So in summary, a local data integration pilot was difficult, but it was also possible. And by accessing the data, it allowed us to answer these questions that were previously unanswerable. In webinar 1, we showed research questions about the transition of opioid use from hospital to primary care, not currently possible in other settings. We talked about identifying as yet undiagnosed axial spondyloarthritis by identifying cases in hospital and then finding what consultation patterns they had in primary care. We've showed you the linkage of hospital outpatient letters with primary care data today. So none of which could have been possible from other data sources. We hope that the learning that we've had in the Jigsaw programme can help others. What sort of team members you need, so people who are able to talk across boundaries between the university, between the NHS, between social care, really robust information governance, which is really difficult, supporting inter-contracts team and other teams within the university. And they, of course, as already said, need to be both skilled and tenacious. Strong partnership with the NHS, which was really necessary in understanding what data items we needed. I think in the future, you definitely prioritise the development of a data dictionary to save some of the time and effort and make things more efficient. But as a first time, that's no criticism of what currently exists. All of this takes a lot of upfront investment, and that's what we're seeing within the national SDE programme. You don't get a return on it very quickly, but by putting all of these things in place, then suddenly you will get a wealth of data and that will allow you to answer clinically important questions. And I think linking the development to these meaningful clinical questions really helps drive delivery, and you can get a focus on what it is that you're trying to do. And finally, I think building this once, expanding it, making it widely available is exactly what should be done, and that is the model of the subnational SDE programme. So I look forward to seeing that programme progress in the coming months and years. Final word is to say that this is not an easy thing to do. It requires a lot of people, a lot of skilled people. I'd like to thank everyone in the Jigsaw programme. Thank you all, because it's been a lot of hard work and sometimes a little bit frustrating as the data has flowed only slowly. And I'm going to stop there. We're going to hear a few reflections from Gareth Thomas, who's the Senior Responsible Officer for the Greater Manchester Secure Data Environment programme, and then we'll finish with a few question and answers for the panel. Thank you.
That's great, Will. Thanks very much. And I don't think it's possible to underplay the amount of tenaciousness and teamwork that's been required throughout the programme. So delighted now to invite Gareth Thomas, who is Digital Innovation Director for Health Innovation Manchester. And then we'll come briefly to our panel. So look forward to hearing Gareth's reflections. And my final thing to say just now is please do put questions in the chat. We'll have 2 or 3 minutes once Gareth has finished talking to address those questions. So yeah, that'll be great. Thank you.
Great stuff. Thanks, Charlotte, and thanks, Will. So just to say, the experiences that Will has just described exactly mirror my experience and my team's experience in developing the Greater Manchester secure data environment. And I think the team should be congratulated on what they've achieved with the Jigsaw programme. I'm also very grateful for Will for his time as part of the GMSD, sort of giving us the benefit of the insights of learning and his steerage in terms of what we're doing with the GMST. So this really is a sort of a microcosm of what we're experiencing now. So I'll try to summarize what I think are a few key themes that we've heard described here today, and also are reflective of the wider FTE program. So first thing, this is a really complex operating landscape. That, this is new ground. The relationships between organisations are not defined, and this is in the context of an evolving strategy, as Will said. This is part of a national strategy, which actually at the start of the project wasn't there. So it's complex, and relationships and organisations are working in partnership, but not as part of formal arrangements. Governance is a huge issue here. So this is all first of type work. We're breaking new ground with our data access permissions. These often require senior national level approvals. They require consideration over data controllership, and really a lot of work to pull apart the complex questions we're trying to answer. I think what will become apparent is in some areas we can standardize some of our approach to data governance, but there'll always be deviation and variation from these pathways, and it's important that we can be flexible around that. Will's emphasised the sheer amount of legwork and the logistics and the time taken to get this stuff done, and what that needs is really tight control of delivery, and I think that's what we've seen here with the Jigsaw programme. We should talk about here something around client relationships. So how to manage expectations, timeframes, dependencies with the researchers who, for their own highly valid reasons, want to get on with these projects, but at the same time being able to put a wrap around that and say, look, this is complex, it's iterative, it will take time, and things will go wrong. There's a big piece here around definitions. We'll talk a little bit about some of the data architecture and the data dictionaries. It's really important that all parties understand what it is we're trying to achieve, what our definitions are, and how that might then impact any particular exercise or prioritization activity or future sort of architectural structures. So clarity of meaning and clarity of definition is really important. And then the final piece I'll talk to will be something around sustainability and scale. So I think one of the things that we're seeing now in the Greater Manchester and sub-national SDEs is exactly as Will describes here. So how do we maintain control of scale and scope? What's our technology platform? What are the associated costs and workforce requirements? And finally, what are the types of data sets that we might want to bring in future that give sort of more strategic importance and value to these research endeavours? So overall, thank you for firstly inviting me to comment. It is exactly my experience and the team's experience of the Greater Manchester SDE. The team, I think I've said before, to be congratulated on the work. It really is impressive what's been achieved. And again, I look forward to working with Will to sort of further inform the Greater Manchester SDE development.
Lovely, Gareth. Thanks so much for your reflections. That's really valuable. So we've got probably a minute available from each or more of our panel discussions. Karen, I'd love to come to you first, please, because it's really important that we hear the NHS perspective. So Karen Webb is Northern Care Alliance Data Science Team Lead, and it would be really good to hear how you found it working with the Jigsaw team and any challenges.
It's been brilliant,
You're a little bit quiet there, Karen. Could you perhaps lean into your mic a bit more?
Sorry, can you hear me?
Great. Yes, much better.
Yeah, so it's been brilliant working alongside academia, esteemed colleagues, and being able to bring together, colleagues internally as well to build something new and go on a journey that we've never been on before. Was excellent. I think Will alluded to the term Chinese whispers, and I think that's really kind of prescient in describing this case, because actually we don't necessarily speak the same language, and I think that's kind of forgotten a little bit, that we speak the language of an acute hospital operational data team, and the university speaks in academic terms, and actually being able to meet each other halfway and understand each other was part of that journey. And I don't think maybe we understood at the beginning that would be a challenge. But then speaking about tenacity, working really closely myself and Louise to try and translate the the complexities of both sides and find a path forward was, you know, a really good experience to go through. And I think we've developed long-term potential for relationship between the organisations now. So yeah, that's my thoughts.
Thanks, Karen. And that's one of the many lessons we learn, isn't it? That longer term relationships are key to create that sustainability for future partnering. Going to come now to Louise and Elaine, some of the stalwarts of the Jigsaw programme, to perhaps give us one challenge or one of their biggest challenges, and then one take-home message that might be useful to other people working on data integration pilots like this. Louise, I'll come to you first, if that's okay.
Okay. Hi, I'm the programme manager for Jigsaw. It's hard to boil it down to one, and I feel like I'm just repeating what Will and Karim and Gareth have said, but I think building a strong relationship with your NHS partner, I've written down exactly the same as Karim. You need to learn to speak each other's language. Having dedicated IG resource, which is in our case was Elaine, was absolutely essential. There's no way we would have got through this programme without her expertise guiding us through. And my last one is you really need strong risk and issue management skills, I think, for this. You need to expect challenges, try and anticipate challenges and mitigate for them. Over to Elaine.
Lovely, Louise, thank you. So Elaine is Dr. Elaine Mackey, who's our Information Governance Manager. Thanks, Elaine.
Yeah, hi. I think the one takeaway for me is that it's really important to understand your local situation if you're working with an NHS trust. And make sure you're talking to the right people. Yeah, be clear what data you want, what items you want, where is it hosted, who owns it, they're the keys. What's your national and local approvals that you need? Get the appropriate permissions.
That's brilliant, thank you. Okay, so everyone else can relax now, your work is done. I would like to thank everyone very much indeed, in particular our discussants who've volunteered their time, panellists and speakers. Most importantly, patients who have contributed through their PPIE involvement and their research participation in this work, and also to the funders and collaborators who've allowed it to be possible. And I look forward to hearing the progress that's built on the back of this programme in years to come. Thank you very much, everyone.
Thank you. Bye now.
Thank you.
Thank you.